Hello, my name is Dylan Price. Today I will be reviewing the scholarly project titled Increasing Gynecological Screenings for Sexual and Gender Minority Individuals. First, I will review the members of the project committee. The committee chair was Dr. Elizabeth Buck. The second reader was Dr. Jennifer Theo, and the community committee member was Dr. Anthony Strickland. I will now provide a brief review of the purpose of the study. Cervical cancer is largely preventable with standardized screening recommendations and accessible testing. However, there is no specific guidelines for non-cisgender heterosexual individuals, leading to knowledge gaps among providers and patients. Historically, this population has experienced systemic and social discrimination, resulting in a widespread reluctance to seek health services. This has resulted in a decreased adherence to routine cervical cancer screenings within the sexual and gender minority population, which is disproportionately affected by cervical cancer. This quality improvement project aims to address the disparity by assessing whether self-collection HPV testing improves adherence compared to standard clinician-collected cervical sampling. The project focuses on providing a secure and private testing environment to enhance patient autonomy, comfort, and privacy, ultimately encouraging testing completion. The literature consistently demonstrates that sexual and gender minority individuals experience a disproportionate burden of cervical cancer risk while simultaneously engaging in cervical cancer screening at significantly lower rates than their cisgender heterosexual counterparts. From a risk perspective, multiple studies have identified higher prevalence of lifestyle and biological factors within the SGM population, including increased rates of nulliparity, tobacco use, obesity, and alcohol consumption. These factors independently associated with increased cervical cancer risk and collectively intensify vulnerability within this population. Beyond clinical risk, the literature emphasizes that this population has experienced discrimination and stigmatization within the healthcare setting and are repeatedly cited as major contributors to the screening non-adherence. Many SGM individuals report prior negative healthcare experiences, including misgendering, lack of provider knowledge, and concerns regarding psychological safety during reproductive health encounters. These experiences often result in delayed or avoided preventive care. Socioeconomic stability further compounds these barriers. The SGM population is more likely to experience poverty, lack of consistent healthcare coverage, and face transportation challenges. Together, these factors reduce access to routine preventative services and exacerbate disparities in cervical cancer screening rates. Importantly, the literature also highlights significant knowledge deficits among SGM individuals related to cervical cancer risk and screening guidelines. Misconceptions regarding eligibility for screening, particularly among transgender men and non-binary individuals, contributes to low uptake and inconsistent screening behaviors. In response to these challenges, emerging evidence supports that self-collection HPV testing is a feasible patient-centered alternative to clinician-collected cervical cytology. Studies suggest that self-collection reduces physical discomfort, minimizes gender dysphoria, and increases perceived autonomy and privacy, all of which are critical drivers of screening engagement within the SGM population. Collectively, the literature establishes a clear gap in equitable cervical cancer screening delivery and supports the need for an innovative, trauma-informed, and gender-affirming intervention. These findings directly are informed by the development of this project and underscore the rationale for implementing the self-collection HPV testing service within the primary care setting. Now, onto the theoretical framework for this project. This project is guided by the model of strategic management of change. This model was chosen because it allows for a structured examination of factors contributing to screening non-adherence while supporting the development of a practical, context-appropriate intervention. The first dimension of the model is content, or the what, which defines the problem and the proposed intervention. In this project, the problem is how low adherence to routine cervical cancer screening among the SGM population, and the proposed intervention is the use of a self-collection HPV test. The second dimension is context, or the why, which considers internal and external factors influencing the problem. Internally, the literature identifies knowledge gaps related to HPV risk and the fear of discrimination as major contributors to non-adherence. Externally, socioeconomic instability, lack of healthcare insurance, and systemic barriers to care further limit screening access for this population. The final dimension is process, or the how, which focuses on implementing evidence-based interventions in practice. For this project, self-collection HPV testing is offered as a patient-centered, trauma-informed alternative to clinician-obtained cervical cytology, supporting patient autonomy and improving accessibility within the clinical setting. Overall, this framework provided a structured and patient-centered approach to guide the intervention design, implementation, and evaluation for the project. Now onto the methods and design. A mixed methods design was employed in the study, integrating both quantitative and qualitative analyses in order to comprehensively evaluate the effectiveness and acceptability of the intervention. This approach was selected to assess not only screening completion outcomes, but also participant experiences influencing these outcomes. The quantitative analysis compared completion rates of standard cervical cancer patients with those of self-collection HPV screening conducted in the clinic. Data on screening completion was extracted from electronic health records, anonymized, and recorded in a secure data collection sheet. This method allowed for an objective comparison of pre- and post-intervention screening behaviors and directly addressed the project's primary inquiry regarding whether the introduction of self-collection testing increased screening uptake. The qualitative analysis involved an anonymous questionnaire that collected data on sexual orientation, gender identity, income, insurance coverage, and prior adherence to routine cervical cancer screenings. Open-ended responses explored themes of comfort with testing, reluctance to engage in routine testing services, and the likelihood of future use of the self-collection HPV service. Now discussing the participant sampling setting. This study was conducted in a private primary care practice in a large metropolitan area in the Midwest. The practice serves a small population within a membership-based care model. Of these individuals receiving care within the practice, approximately 355 met inclusion criteria. Convenience sampling was accrued a total of 4 participants. The study employed a longitudinal design utilizing an 11-week intervention period. The pre-intervention period occurred from April to October 2025, and the post-intervention phase occurred from the October 2025 to January 2026. Concerning instruments and procedures, the data collection tool was developed by the authors based on the USPSTF and the WPATH guidelines, along with insights from the literature review on non-adherence to routine cervical cancer screening among the SGM population. Its primary purpose is to measure the intervention's effectiveness. The intervention was developed based on using a testing method that is approved by the U.S. Food and Drug Administration and is supported by evidence-based, patient-centered literature. To comply with HIPAA regulations, only essential data was extracted for the project. During the retrospective chart review, personal identifiers were removed to ensure anonymity. The data was numerically coded and stored in a password-protected file in a locked office to maintain confidentiality. Additionally, there was no direct participant interaction made during the research. Now on to the data analysis and presentation of data overview. In this project, descriptive statistics were used to analyze the demographic data of the participant population and the prior history of cervical cancer screening comfort. An upper tail z-test for the differences of 2 proportions was used to compare pre- and post-intervention rates of cervical cytology sampling and self-collection HPV testing uptake. The primary goal of this test was to determine whether a statistically significant difference existed between the 2 tests. Now on to descriptive statistics. The demographic data collected through the questionnaire responses of the 4 participants identified that 100% reported being transgender. 100% also reported having current health insurance. 75% of the participants were between 25 and 44 years. 75% reported an annual salary between $25,000 and $49,000. 50% identified as being heterosexual. With respect to cervical cancer screening data, only 25% of participants reported receiving either a PAP or HPV test in the last 5 years. 25% reported using self-collection HPV testing services previously. Concerning comfort with testing, data analysis revealed that 50% reported the self-collection HPV test was extremely comfortable and 25% reported it as somewhat comfortable. Now onto the quantitative analysis. An increase in screening uptake was observed. However, the Z-test indicated that screening uptake within the self-collection HPV testing service was not statistically different from that of standard clinician-obtained cervical sampling, as indicated by a Z-score of 0.82 and a p-value of 0.206. The narrow confidence interval indicated a true change in ratio. However, given the 0 in the interval, there was no significant evidence of a directional change. The post-hoc power analysis revealed an achieved power of 0.2046, indicating the study was markedly underpowered. This is largely related to the small population size. Now, the quantitative analysis review. While the quantitative analysis provided a statistical evaluation of the intervention's effect on cervical cancer screening uptake, the qualitative analysis explored specific factors that affect screening uptake. Given the small sample size of 4 participants, data saturation for qualitative analysis was not achieved. Furthermore, none of the participants submitted a response for the post-intervention questionnaire. As a result, the qualitative analysis focused solely on the pre-intervention questionnaire data. In addition to the social and demographic characteristics explored in the questionnaire, open-ended responses examined comfort with testing and a history of non-adherence. 50% of the participants provided narrative feedback to these open-ended questions. Given the low saturation of narrative feedback in the questionnaire responses, no themes emerged. An analysis of narrative feedback identified in the open-ended questionnaire responses revealed discomfort with standard clinician-based cervical sampling. One participant reported, "I had not received the test due to discomfort with gynecological care in the medical setting." Another narrative feedback revealed a knowledge deficit related to the need for routine testing. One participant reported, "No one ever recommended that I receive one, and it is not something I would have done on my own, mostly just because I didn't understand the importance of the degree where I would make an appointment of my own volition." Now, onto the discussion for the limitations of this project. While a nominal increase in self-collection HPV screening testing was identified in the quantitative analysis, the project had several key limitations that hindered the generalizability of the intervention to the SGM population. A primary limitation of the project was a small sample size, as evidenced by the achieved power of 0.2046, indicating that the project was markedly underpowered. Subsequently, the small sample size prevented achieving adequate data saturation for a thematic analysis. The qualitative analysis is further limited by the absence of post-intervention responses, which means it is based only on the pre-intervention questionnaire response data. Another limitation was the out-of-pocket testing costs, which likely reduced the recruitment and further contributed to the small sample size. Furthermore, the 11-week intervention phase limited the time frame for participant recruitment and follow-up. Recognizing these limitations are essential for the contextualization of the project's outcomes and highlights the need to be addressed in the future research. Now, onto the discussion portion of the project findings. This project demonstrates that implementation of a low-barrier, patient-centered HPV data collection screening protocol was both feasible and acceptable within the primary care setting that provides gender-affirming care. Although overall screening uptake was limited by a small sample size, participant feedback highlighted increased comfort with cervical self-collection compared to clinical obtained cervical cytology. Stakeholder feedback indicated that the protocol was straightforward to implement and could be sustainably integrated into routine clinical practice. However, the identified $45 out-of-pocket expense emerged as a significant barrier to participation, aligning with the socioeconomic challenges as described in the literature. The qualitative findings mirrored existing evidence, particularly regarding discomfort with traditional clinician-based screening and gaps in knowledge related to cervical cancer screening guidelines. These findings further support prior research suggesting that self-collection HPV testing represents a trauma-informed and gender-affirming alternative for individuals who are experiencing barriers to routine screening. Overall, these results affirm that self-collection HPV testing is a viable intervention to reduce structural and psychosocial screening barriers and has a potential to improve equitable access to preventative care when financial barriers are addressed. Now, onto the discussion for the implications for practice. The integration of self-collection HPV testing into routine clinical practice has numerous implications for nursing practice, including the provision of individualized, patient-centered, trauma-informed care for the SGM population. Self-collection HPV testing provides an alternative to standard clinician-obtained cervical sampling, which directly mitigates various driving factors contributing to the population-wide non-adherence by eliminating the invasive nature of standard testing. Self-collection testing allows for a greater autonomy and promotes gender-affirming care by respecting individual privacy, confidentiality, and autonomy. Furthermore, this protocol can be seamlessly integrated into standard clinical practice, as demonstrated by its compatibility and congruency with current cervical cancer screening recommendations. Integrating this individualized approach to addressing population-specific care needs improves patient trust and enables the development of a therapeutic patient-provider relationship. A trusting relationship increases opportunities for patient education, potentially mitigating the prevalent knowledge deficit regarding screening recommendations and risk levels within the SGM population. By enhancing screening accessibility and patient education, providers help reduce this persistent health disparity. Now on to the conclusion. This study aimed to improve cervical cancer screening uptake among SGM individuals by providing a self-collection HPV test service as an alternative to standard clinician-based cervical cytology sampling within the primary care setting. An upper tail z-test of 2 proportions was conducted to compare the pre- and post-intervention rates. Although the z-test revealed a nominal increase in intake, the change was not statistically significant. The qualitative analysis revealed barriers to care, with feedback indicating reluctance to adherence to testing recommendations due to discomfort with clinician-obtained testing and a testing knowledge deficit regarding current recommendations. This feedback aligns with the barriers identified within the literature review. These findings emphasize the need for individualized, patient-centered testing availability. Now to discuss the DNP program impact. The DNP program has impacted me in many ways as I have progressed through it. As a student in a BSN to DNP program, the transition from experienced nurse to a novice nurse practitioner has been both challenging and eye-opening. This journey has shifted my perspective from task-based nursing to one grounded in evidence-based system-level decision-making. The program has equipped me with the tools to become an effective leader and advocate, promoting high-quality, patient-centered care. It has strengthened my ability to think critically, apply research to practice, and contribute meaningfully into the improvements in the healthcare delivery. Additionally, my scholarly project has inspired me to pursue a career focused in addressing the health disparities within the sexual and gender minority population. I am particularly passionate about providing gender-affirming, patient-centered care and hope to make a meaningful impact within my community. Here are the references, and thank you for your time.